Covering heat emergencies now. So hypothermia is any body temperature above 38 degrees. But just follow this paragraph here. So anytime you've ever been running a fever, you're over 38 degrees. That's technically hypothermia because you are over 38 degrees. But hypothermia in medicine specifically refers to harmful temperature rise. So when you're running a fever, that's physiological hypothermia. When you're febrile, your body raises your temperature, your hypothalamus raises your temperature because when you're running a little bit hotter, your immune system works better and bacterial propagation is actually inhibited at higher temperatures. So that's helpful to your body. So that's sort of, when we talk about hypothermia in this lecture, we're just talking about harmful hypothermia from a non-physiological cause, like running a fever. So there's a couple of things that fall under heat illnesses. Heat cramps is not actually to do with raised body temperature. It's to do with excessive sweating. We'll cover this in the pathophysiology a little bit later. But it's when you get muscle cramps that develop after lots of sweating or periods of exercise in hot environments. And then you have heat exhaustion and heat stroke, which form, they're not clearly separate disease processes. They're on a spectrum of the same process. So heat exhaustion is just the less severe version. And that's when the body is running too hot and it is causing problems, but you're less than 40 degrees. And heat stroke is when you've crossed over 40 degrees, which tends to be associated with a range of other more serious symptoms, which we'll cover in more detail. So heat, we've covered altitude emergencies, cold emergencies, but really this is Australia. We don't have that many particularly high or cold areas. We're a very hot country. So heat-related illness is responsible for more deaths than all of our other natural hazards combined. So this is one that's worth paying attention to. It's one that you're going to see in your career. As with every condition, the very young and the very old are at heightened risk of these illnesses. But the elderly in particular, whenever a big heat wave, you see it in the news, sometimes a heat wave will have gone through Europe or America or even the southern areas of Australia, Sydney and Melbourne, and a lot of old people will die. The reason is because elderly people aren't able to thermoregulate as well. They don't sweat as much. And also because elderly people tend to get quite concerned about security. And so they'll lock all their windows, lock all their doors. And sometimes you'll go into their houses and I can only describe them as hot boxes. It's like walking into an oven. It can be like 5-6 degrees hotter inside than outside. And they will just sit in there getting very hot and quite dehydrated. Pensioners in particular don't want to run their air conditioners because of monetary concerns. And again, in an enclosed house, that causes big problems. Again, this is something that affects the elderly as medications. So diuretics, so if we flick down to the bottom here, diuretics, which are pretty common in old people, decrease the amount of fluid that you have in your body. So if you have less intravascular volume, you're not going to be able to sweat as much, you're not going to be able to keep yourself cool. And a lot of antidepressants have anticholinergic side effects. Now you remember anticholinergics from the toxicology lectures. Anticholinergics stop your excretory functions, so they stop you sweating. Normally there are a couple of ways that you can get rid of heat. You can radiate the heat off your skin. You can use convective cooling, like when a breeze goes past you. But humans evolved to use evaporative heating. So we sweat, and then that sweat evaporates off us, and the heat dissipates that way. But there are a couple of things that disrupt that process. So if it's very humid around you, if the air is already saturated with moisture, the sweat will just pool on your body, and if it doesn't evaporate, it doesn't remove a lot of that heat. And then obviously if you're dehydrated, you're not going to be able to afford to expel that water in the form of sweat. So heat cramps, as I said before, aren't actually specifically to do with heat. They're to do with hyponatremia. So when you sweat salty water. And if you sweat a lot, like if you're doing a lot of exercise or you're working in a hot environment, and then you're just drinking water, you're replacing the water but not the salt. As you start to lose significant amounts of that sodium, of that salt, it'll start to affect your muscles depolarizing, and you'll start to get muscle cramps, painful muscle cramps. The treatment is just salt replacement. Electrolyte-rich drinks, Powerade, Gatorade, if they can drink, that's going to solve their problem. Otherwise, normal saline does contain an isoelectric amount of sodium as well. So the concept of thermal maximum is significant for understanding why that heat exhaustion gets more serious as it progresses into heat stroke as we cross over to that higher than 40 degrees Celsius. So the thermal maximum refers to the maximum amount of temperature that human cells can tolerate before they start to get damaged and die. And that's around 42 degrees in humans. So after you start getting over 40 degrees, you're not going to die at 40.5, but you're definitely getting, you're skating on the edge of that danger zone there. Once we start getting over 40 degrees, you also start to get changes such as significantly decreased intravascular volume from excessive sweating. So even though you've still got 2 degrees leeway there between 40 and 42, in reality, once you start crossing over 40 degrees, you'll accelerate towards that 42 degrees pretty rapidly without external intervention from paramedics. So the way these patients will present with heat cramps, as I've said, it's kind of there in the name, they're just going to have cramps. Often their temperature won't be raised or not significantly raised, but they'll have that history supporting it. They'll have been working all day, they're roofers or something, working in summer, marathon runners, something like that, and they've been drinking water or some other fluid that's not containing sodium, and they just need sodium replacement. For heat exhaustion, patients will be hot. This is crucial. They'll be sweaty, and they may or may not be confused. Their temperature will be under 40 degrees. In heat stroke, they're not going to be sweaty anymore. They're going to be hot and dry. They've actually basically run out of sweat. They're so dehydrated. Because they're so intravascularly depleted and their brain is getting cooked, they're going to be confused or unconscious, and their temperature will be over 40 degrees. Now again, this isn't, it's not like 39.9, you're presenting as heat exhaustion, and then you clock over 0.1 more degrees and suddenly your whole presentation changes. It's a spectrum. I was jumping ahead. Yeah, so I guess the last point here is the most important. If in doubt, treat it aggressively. If someone's confused and they're 39.8 and you're not sure whether you're going to be aggressive in your treatment or not, what's the harm? Treat them aggressively and cool them down, and we're going to get into treatment. So first things first, the patient should be moved into a cool area, into shade, into the air-conditioned ambulance if possible. And the treatment is focused primarily on rapid cooling. These patients will have a fluid deficit, but the fluid deficit is not what's going to be causing their most proximal problems. The most important thing you can do is rapidly cool them, and you can replace their volume down the track. So ideally, the best practice is ice water immersion. Rapidly cools the patient, and there's a great deal of case study evidence showing consistent good outcomes with ice water immersion, but it's not practical in the ambulance. We don't carry ice water baths around with us. So what we're going to have to rely on is evaporative cooling. There are several variations of evaporative cooling, but they all involve basically the same thing, which is laying the patient down, wetting them down, or misting them with water, and then either getting a fan or even a bit of cardboard or something, and putting some sort of breeze or movement of air over them so that there's evaporative cooling occurs and that water evaporates. Now, interestingly, you would think you would spray cold water on them. They've actually had better outcomes using warm water because it evaporates so much more quickly, which just strips heat out of the body. And it can lower the body temperature by 1 Celsius every 10 to 20 minutes. To facilitate that faster, you can put ice packs in the armpits and in the groin. You have big blood vessels close to the surface, so they're going to help suck away some of that heat, and also around the back of the neck, because really what you're trying to preserve is the brain and keep that cool. So if you can cool down some of that blood going upstairs, you're going to preserve brain function as well. I guess worth making a note on this that a lot of the research that led to the studies showing really good outcomes in evaporative cooling come from Afghanistan and other Middle Eastern countries where humidity is really, really low. So evaporative cooling works awesomely. If you're treating someone in North Queensland in summer who is having heat stroke, evaporative cooling is likely to be less effective because the ambient humidity is going to be so high. You can fan them, but the water's not actually going to evaporate off them so well. So evaporative cooling is still recommended. That's what the evidence base supports. But just be aware of that caveat that you may not see quite this level of cooling, 1 Celsius every 10 to 20 minutes in high humidity environments, because the evaporative cooling is going to be much slower. So you want to cool these people to around 39 degrees, and that temperature, the danger zone's passed, and the body can just slowly cool itself after that. But the brain's going to be preserved, the organs are going to be preserved. As I said before, volume depletion will be present, but it doesn't take priority. So patients who are very hot, say 41 degrees, they'll eventually progress to hemodynamic collapse. And if someone's got very low blood pressure, you can't get a radial pulse, you're going to be thinking, we need to get fluids into this person, we've got to raise their blood pressure. The best way to treat hemodynamic compromise or cardiovascular collapse in a very hot person is to cool them. As you cool the body and you cool the brain, all of the body's normal hemodynamic processes to maintain its normal hemodynamics will switch back on, because what's happening is that they're shutting down as the person's getting hotter and hotter. So the person doesn't necessarily need a huge fluid load. They just need to be cooled enough that the normal vasoconstriction and the normal feedback mechanisms can take over again, and that's actually the best thing you can do to maintain their cardiovascular status. After they have either been cooled or you've started the process and you're sort of looking for something else to do, that's where it can be great to get an IV and start giving them some fluid. And if you have them available, cold fluids, some ambulances do keep a bag of saline in the fridge, and you can use that. That will help cool them quicker. So the fluid administration, if you're going to give, you will need to give fluids, but after you've decided to do that, you only want to give 10 to 20 ml per kilo. They will have a fluid deficit. It tends not to be a huge one. And the reason for that is that if you give it too quickly, it has been associated with pulmonary edema. Again, when your temperature is that high and your normal mechanisms aren't working to maintain homeostasis, your lungs are so, what am I trying to say here? It's so easy, your lungs, So as I said, these patients will have a fluid deficit, but when you are replacing the fluid, they're not going to need litres and litres. So 10 to 20 ml per kilo is fine, and you're just titrating it to normal endpoints, so blood pressure, heart rate, and conscious state. They'll be able to fine-tune the fluid requirements in hospital and in ICU. And the reason is that, as I said before, when your body temperature is so high, your normal mechanisms, your normal feedback mechanisms to maintain homeostasis are shutting down. And your lungs, because the alveolar membrane is designed to be permeable, it's the first place that any sort of fluid shifting is going to show. So these patients can get pulmonary edema in heat stroke with over-aggressive fluid resuscitation. Again, that problem will go away as you cool them and those normal mechanisms come back in place. Now, going all the way back to slide 2, I think, when I was talking about the difference between physiological versus pathological hypothermia, any pyretic medication like Panadol, we're used to giving that when someone's temperature is up. It's only useful in physiological hypothermia, because if your body's running a fever, it actually has the capability to slow that temperature down and lower it if it wants. Pathological hypothermia, like heat exhaustion or heat stroke, represents a failure of your body's thermoregulatory mechanisms. So giving a paracetamol, it will do its job. It will tell the hypothalamus to lower the temperature at endpoint, but your body, if it was able to do that, it would have. Those mechanisms have failed, which is why the body is now getting hotter and hotter. Now, this has largely, I think, been put aside now, but you may still, if you do any further reading, still run into the idea of shivering thermogenesis being a problem. There was some thinking for several decades that you needed to give patients IV benzodiazepines, like a bit of IV diazepam or midazolam, to stop them shivering as you cooled them, because the shivering would just make them hot again. In reality, it's not really been shown to be true, whereas giving patients IV benzos who are already this unstable precipitates the risk of airway or other cardiac compromise.